Good afternoon. Welcome to the Health Informatics Seminars. I'm Dave Potenziani. I will be serving as your host today. We are continuing an experiment we began last term of having a conversation rather than just a presentation. Today, we're going to explore some approaches to access healthcare quality and improvements that stretch from the sub-Saharan Africa to the United States. Our guest will talk about her work in developing health information systems to do just that, looking at the commonalities between these settings rather than just the differences. But first, we should do a little bit of housekeeping. Please remember, today's meeting is being recorded. Do mute your microphone until you wish to ask a question or make a comment, which you can do at any time. You don't need to wait for me to call on you, but just begin talking and we will work you into the conversation. And that's because this is meant to be a conversation where questions can be raised, points made, and learning takes place by everyone. Nevertheless, some may prefer to put their ideas, comments, and questions in the chat. That's fine. I'll be monitoring it. So if you do that, I am happy to bring your thoughts to the attention of everyone. So let's begin. Today, we're going to talk with Dr. Amy Finnegan. Dr. Finnegan is a consulting health systems data scientist specializing in value-based care, population health, and implementation analytics. She studied public policy with a concentration on interdisciplinary data science and demography, earning her PhD from Duke University. We will forgive her for that oversight. She has led multi-site EHR harmonization efforts, designed quality and risk stratifications dashboards, partnered with clinicians and operational leaders to conduct documentation, measurement, and to connect documentation, measurement, and financial incentives. Her work bridges global health systems, performance models, and the U.S. reimbursement framework, such as Medicare Advantage and the Medicare Shared Savings Program. Full disclosure, Amy and I worked together at IntraHealth International on a project to explore the potential of a machine learning approach in Uganda. Amy, why don't you give us a quick view of what topic you'd like to begin with today?
Great. Thanks, Dave. And hi, everyone. Thank you for having me. I did bring a few slides with me because I wanted to kind of scaffold our discussion here. And it also helped me think through some of these connections that I'm starting to make. So I'm reimagining my global health work through value-based care framework. So a lot of this might sound familiar to you all. And I'd love to talk more about it and kind of learn from each other as we go. So as Dave said, we met working at IntraHealth International to enable digital systems to take hold in low and middle income countries. And since USAID was dismantled in early 2025, I've been reflecting on that work and how it translates into the US healthcare system. So for 6 years at IntraHealth, I worked in global HIV programs under intense performance pressure, epidemiologic targets, funding tied to outcomes, standardized indicators, and what felt like constant reporting. And what I've come to believe is that the structural lessons from that work are directly relevant to value-based care in the US. So this talk is really about architecture and how we organize measurement into management. So let's dive into global health. In 2023, PEPFAR was launched as the largest global HIV initiative in history. Targeted technical assistance played a major role. That was through drug supply chains, laboratory capacity, workforce strengthening, and digital health, which was a specialty of IntraHealth, and operationalizing care at the facility and community level. And over that same period, AIDS-related mortality declined dramatically. But the inputs alone don't produce those outcomes. They have to be coordinated. Coordination in PEPFAR.
Amy?
Yes.
A quick correction. It was
Yes,
2003. Sir. Your slide said 2023.
It does say 2023. Oops.
Okay.
Thank
All
you
right.
so much.
Now your curves make a lot more sense.
Yes, thank you. Okay, so coordination between everyone involved. In PEPFAR, that was driven by ambitious targets pegged to epidemiological projections, and funding was tied to achievement of those targets. Standardized indicators were reported weekly, monthly, quarterly, and annually, and implementing partners were evaluated against the epidemic and against each other. And sometimes people called it feeding the beast. And at times it definitely felt that way. But my role there wasn't to design that reporting system, it was to make it useful so that reporting didn't crowd out the use of that data. So the organizing structure I really want to talk about today is a cascade. And that was really what was underneath reporting about HIV and addressing the HIV epidemic. So a cascade anchors every metric to a defined population. It defines a sequence of necessary steps, and it makes drop-off visible and it aligns the weekly operational cadence with annual accountability against targets. And it doesn't eliminate complexity, but it helps discipline it so it can convert that reporting that we were doing into management. So let's look at the HIV treatment cascade, and I want to go in a little bit of detail because I'm assuming that folks in the audience may be less familiar with this. So let's take a look at the cascade. Each bar shows performance conditional on the prior step. Each step looks pretty strong, but small inefficiencies can really compound over the course of the cascade. So in this example, which is pretty typical of countries that I worked in the last 6 years, at the time mortality was really declining. In this example, 90% of people living with HIV know their status, and that's really strong case finding, but it still means that 10% remain undiagnosed, which sustains disease transmission and delays care. So in this step, at IntraHealth, we overlaid testing with estimated HIV prevalence geographically and with clinic entry point by age and sex to provide a game plan to improve case finding. So taking all of that data that we had available and using it for program implementation is one of the things that I really see as being a tie between both value-based care and global health and HIV. So once diagnosed across our programs, linkage was typically pretty excellent. This is often a strength in the countries where I worked. So systems know how to connect people to facilities, but there could be challenges with rural access and transportation barriers. But retention is where fragility started to appear. Missed visits and migration, life instability, this is where the cascade really started to erode. So instead of focusing just on linkage, we looked at drop off after the initial visit. If someone doesn't make it to their second visit, we might not ever get them back. So how can we prevent this? An example of IntraHealth's work is that in Uganda, lay workers often were helping clients stay connected to care, but the workforce was constrained and really imbalanced. So we asked what was the optimal ratio of clients to health workers that would maximize retention. And then we were able to dynamically redistribute our limited resources to maximize retention in rural Uganda. Once we move to the next part of the cascade, people who are retained, ART initiation is pretty strong. Medication availability is really not the central barrier in most mature programs. So now provider variation can be a barrier, such as getting clients switched to more effective drug regimens and multi-month dispensing to improve medication adherence. And the last step is viral suppression. And if your viral load is suppressed, you can't spread the HIV virus. So this is the kind of light at the end of the tunnel of this cascade. Suppression in this case among those on ART is pretty good, but it's not perfect. So adherence and continuity really still continue to matter. So missed refills and appointments are a primary challenge in chronic care delivery. So at IntraHealth, we asked ourselves, how do we put the right metrics in front of clinicians so they can treat the patient in front of them better and not lose an opportunity to offer them improved drug regimens or the kind of social support they needed. So that's what we developed in Guatemala with clinicians and helped roll it out across Central America. So when we look at the equation against the 95, 95, 95 targets, um, overall viral suppression is about 70% of all people living with HIV. So while the bars really look pretty strong, small drop-offs compound at the end of the day, and the program is strong in this case, but improvable.
So
So
Amy,
let's go.
before you
Oh,
leave that slide,
yeah.
um, this sounds like it's predicated on being able to uniquely identify every patient.
Yeah, it's better when you can identify every patient, but at the diagnose level, you don't necessarily know who that individual patient is. You want to make sure that you're looking at the age and sex disaggregation of the HIV epidemic and hitting targets of inviting people for testing in disaggregations you think are high risk. And then once you link them to care, that's when you initiate that in some cases, paper health records or electronic health records. In Guatemala, we had a point of care system that we had developed from an open source tool called ComCare, where now we have an individual line list of all the clients who have been linked to care. And we scheduled their next appointment, and we could tell when they had been retained or not and what ART they were on. So a lot of these steps in the cascade can depend on line listed individual data, but there are definitely things you can do when you just have population disaggregated data.
Okay. I asked the question because we're going to come back to that a little bit later, I
Okay.
think.
Yeah, it sounds good. I mean, in these countries, part of what PEPFAR was doing was funding digital data systems, and IntraHealth helped develop and implement some of those. But there's definitely stuff we can do with the data we have, and that was one of the really exciting parts of working on this. So when I returned to US healthcare, in early 2025, I saw something pretty familiar. The number of performance measures had grown dramatically. So in 2012, I had taken the global path because I thought the only way to improve US healthcare was to go into politics. And little did I know when I would come back in 2025 that we had this proliferation of metrics. We had started measuring performance, and the measures had grown dramatically. Of these measures, some affect payment and some don't, some overlap, some compete. I don't know all 889 measures, so don't grill me on that, Dave, when we get to that point. But in this case, measurement doesn't seem to be the problem. The question is whether those measures are organized into a coherent flow. So
Mhm.
without some kind of flow architecture, proliferation can really just become noise. And I'm also just kind of reflecting on the US healthcare system now and hoping to get some more hands on experience. But I created this Medicare Advantage cascade that I hope resonates with both what we were doing in HIV, but the situation in the US.
For
So,
those under 65, can you describe briefly the Medicare Advantage program?
yeah, so Medicare is a government program for health insurance for seniors. So you have to be, I think, 65 in order to enroll. And Medicare Advantage is more of the program where you have a choice in which provider that you go with. So it's combining that US government provided insurance infrastructure, but also some individual choice so that you can uh, right size the benefits that you need for your particular case.
And you're signing on to a private health insurance company to
Yeah.
essentially manage the financial side of your care as well as to support the network of providers.
Hmm.
Okay.
Yeah. So the way that Medicare Advantage providers are evaluated and reimbursed is around attributed members. So you might have a healthcare system that is responsible for members, which is in their service area. And so in this example, 78% of attributed members are meaningfully engaged in primary care. The failure drivers could be passive attribution, network leakage, member disengagement, and access constraints. We go to the next level, which is the annual wellness visit. You guys hear my dog barking?
Your audio's fading.
Okay. My dog is barking in the background. So you can't hear him, then
Okay.
I'm going. So the annual wellness visit is the structured documentation moment, which is often the emotional bottleneck. So you could have scheduling capacity, outreach discipline, competing priorities, and no shows. But once you get to the annual wellness visit, documentation is pretty robust. Once patients show up, we're able to activate that engine of documentation, which rolls back into the risk adjustment for your population and reimbursement that you receive. So you want to make sure you have good documentation on your attributed members because reimbursement for the health system is based on that population. And then once you understand your population, they're coming in for care, the care gap closure reflects that sustained follow through. So it's not enough to document risk, but chronic disease management has to occur. So you want to start thinking, like we did in PEPFAR, about medication adherence and care coordination breakdowns. So when you multiply these percentages, only about 43% of the attributed population is effectively managed through the full chain. Again, the individual bars look pretty strong, but the cumulative effect is smaller. And the stars you see at the right reflect that kind of reality. So this organization would get a bonus when they reach 4 stars. They're close to the bonus threshold, but they're not fully optimized. So you want to think about which parts in the chain are contributing, would be the strongest levers to get you over that 4.0 threshold. So across both systems, the disease changes, the financing structure changes, the regulatory context changes, but the seams between each of those points where systems fail are pretty consistent. The cascade teaches us to define the population, sequence the necessary steps, make those drop-offs visible, and align our weekly limited attention with that annual accountability, which is driving revenue and reimbursement for systems. Advantage. So in both settings, we have data, we have dashboards, we have models, but here's what I learned and I wanted to share with you. Prediction models don't save systems. Data science doesn't save systems. Attention discipline does. So how do you think about these drop-off points? Risk adjustment without workflow integration can fail. Dashboards without accountability can fail, and data without ownership can fail. Cascades are powerful not because they produce more metrics. They're powerful because they help us discipline our attention at different points. They tell you where to look, they tell you who's falling out, and they align operations, workforce, and financing around the same flow. And I wanted to also put in a plug for AI because I know that that's very exciting, but how do we leverage it to strengthen those transition points? Like we did in Guatemala, we can use AI to predict who's at risk of disengagement. We can flag documentation gaps and optimize our outreach, but without this architecture, AI can just end up optimizing as well. So I hope to leave you with the thought that architecture turns reporting into management, and that's the bridge that I see between global health performance systems and value-based care. And I look forward to a rich discussion with you all.
So let's go back to that unique identifier issue I brought up earlier. Um, I mean, what you outline in your Medicaid Advantage example is consistent within a single Medicare Advantage program because they will know who their clients are and they will be able to track them throughout the clinical cascade. But if you did what I did last year and I switched from one company to another, all of a sudden I disappear in one place and reappear someplace else. The United States lacks a national identifier to uniquely identify each person, at least legally. So what would that do to your approach if you have the leakage like that? And I'm not asking you to solve the national identifier problem, but we really do need to note it.
Yeah, for sure. I think that there are a couple of ways that that kind of sneaks into this because the plan has this attributed population, but people are switching between plans. So you get a new member that you don't know much about. You could be getting someone who, didn't go to their primary care, didn't adhere to their medication, and when they come into your clinic for their annual wellness visit, then you have to learn as much as you can about them to both provide care, but also to track that data that got lost in the other system. And that becomes really important for the reimbursement that you get because your rates are set adjusted by the population that you serve. So you really need to understand your population because there is switching. There's people coming in who are sicker, and that getting that part right really affects the financial situation downstream.
It also sounds expensive if you have to sort of start over again, collecting data on a person every time they switch plans. I mean, I'm also looking at this in the comparative context that U.S. healthcare costs per person twice as much as healthcare in every other country. I mean, at least twice as much. So it seems like we have a problem here that ought to be solvable. We are actually not really discussing it much.
Yeah, I think that some interesting solutions that I've seen and have worked on this in Africa as well is having the person carry their record from place to place. So this was a big idea we worked on a couple years ago with the MasterCard Foundation, where they, were really inspired by the M-Pesa model because in Africa, a lot of innovations have been able to leapfrog, right? Like you don't require the like the rotary phone in your house and then you have to go to the bag phone and then you go to like a smartphone. They're already like coming alive when the smartphone already exists, so they're able to leapfrog some of those systems. And there is a debate around infrastructure at the health system, like we're building national health information systems. What if we don't have to wait for the government to implement that? What if we can just give every individual their health information? They go from site to site, and maybe it's on a card, and you have an NFC reader, and you just tap it, and the health facility knows everything about you instead of having to wait for the government to catch up. That's definitely some of the solutions that I've seen out there.
That that was that was an idea that caught some traction in the US in the early 2000s of personal health records.
Yeah.
But the EHR companies created, as Epic did for their MyChart, so that each person can access their medical records online.
Hmm.
And so, but the challenge is I have some of my care at UNC Health and some of my care at Duke Health, and they're supposed to be able to talk to each other, but it is a difficult thing to bridge these EHR systems. How
Yeah.
could you see that? I don't want to dwell on this issue for our whole time, but that's one of those gotchas in the American context that you're saying doesn't really exist in the same way in a low and middle income country context.
Well, in a low and middle income country, it's paper files, right? So your paper file is at clinic A, and then you go to clinic B, and your paper file's at clinic B, and nobody knows you. In some way, that's mitigated because the rural areas are kind of small, and you know everyone. So there may only be one clinic, but um, I have seen actually moving from Durham to Greensboro, North Carolina, where I am now. Enrolling in Novant Health, and then I have another one at Cone Health, and I had my Duke one, and I have my UNC one. There was a setting in there that was like, do you want to share your My Charts across um, facilities? So I think that they're thinking about it. It was possible. And I remember also having to, like, I could ask my previous primary care provider to fax it, to my new primary care provider if I signed all the right paperwork. So it's definitely not seamless. But from a health system perspective, you can kind of look at claims as well.
One of our viewers has contributed an idea.
Yeah,
Health information exchanges that exist, I think, pretty much in every state now, are meant to help with the problem, the portability of or access, remote access of healthcare data, in addition to what Epic and Cerner and others have developed. So the idea there is that you can look up a person in particularly the early work was in linking emergency departments so that they could look up somebody who had been to a different hospital's emergency department if they were in a different network, and then be able
sure.
to um, look at their previous medical records. So, and this is one of those questions where I guess there are solutions, but they're still piecemeal.
Yeah, I think that we have a lot of tech debt, right, of these systems. I see someone commenting about health information exchanges and standards, right? We've developed some things to link records together, but it's not free to implement them. So I think that that can be a barrier as well.
Okay,
But I'd
so
love to hear.
this viewer also contributed the idea that the trusted exchange framework and common agreement, TEFCA, is supposed to address this. It's a national initiative to be able to make these systems interoperable so that you can look up electronic health information about a person remotely, you know, if you have the rights and so forth to do that. But still, it's not necessarily what you described in terms of a person in the programs that you outlined where they can be tracked over time to be able to look at adherence to medications and so forth. And I'm thinking in the American context that you know there's a host of other issues besides HIV, like diabetes care and the like, that would benefit from this approach. How would you approach a payer who has this health network to be able to explain what you've done and advocate for a similar kind of approach?
Yeah, I mean, that's a good question. I'd love to hear of some of these other frameworks because I think there is a lot of good work of people trying to create health information exchanges. I worked on a couple of these in, Rwanda is trying to create a health information exchange. We've got our enterprise architecture and all of that good stuff. There's FHIR, obviously, that we can use to connect systems, but we still need we need someone to hurt badly enough in their pocketbook to make this work, I think is my hot take about that.
But I mean, so, all right, Deborah Swain, you have your hand up.
Yes, I'm trying to be polite that way, but once upon a time, we used to say this data was like bank data. You take it wherever you go with you, it's your data. So, where are we on that question? And then I have a global issue question, but where are we? It's my data.
I don't know much about that in the US healthcare system, but I have been involved in those conversations globally. And yeah, I mean, there are some countries that are leading the charge on that, but there are also conflicts, like I mentioned. So, someone
In
else
Well,
the
know?
yeah, it's up to the companies, I guess, and who owns the data, but it's a great movement to think about.
It's a gray area legally
Yes,
Hmm.
in
but
the
it's,
United States.
yes, but it's going to be time soon to make it black and white, but I guess. But my other concern, Amy, I'm just in shock about USAID disappearing. I mean, there are hundreds of thousands of deaths apparently. What is happening, at least to the data that was once collected through USAID?
I think that was one of the things that made my heart drop was the demographic and health surveys have been collected in um, 80 countries probably for the last 30 years. And it's the best population data we have available to evaluate our progress on the sustainable development goals and, global population trends. And so when that project was ended, that was kind of one of the last straws for me. But the Gates Foundation has actually stepped up to provide funding, kind of bridge funding, to keep it running, to finish those surveys that were already in the field at the time USAID was shut down, and also to invest in figuring out what to do next. So a lot of the private foundations have been willing to bridge the distance and create a space to talk about what to do, but have not necessarily been willing to, fund directly programs that USAID was funding. Unfortunately, a lot of the PEPFAR programs did come back online. There was a gap for sure, but we've seen a lot of the programs come back online at lower funding levels as well.
You give me a little hope. Thank you, Amy.
Amy, earlier you talked a little bit about dashboards and their utility and their limitations. In the American context, how do you think the kinds of approaches that you had developed elsewhere might fit how American healthcare systems look at this kind of data and utilize these kinds of dashboards?
Yeah, I mean, it's a lot of basic disaggregation by age and sex, the different entry points. I haven't really gotten my hands on a value-based care dashboard, but I would love to think through that with, a diabetes case, for example. And so instead of just looking at the averages, how do we look at the 5-year age groups by sex, by geography and location? I think there is a lot of data now coming into the health space around the social determinants of health, or SDOH. And I think even Epic has, they call it the wheel, and different ways that clinicians can bring in that data and look at it. But I would love to see those breakdowns at each point in the cascade. I would love to see dashboards that don't just look like a bunch of dials, right? Like I always think about it in our HIV programs, a lot of times everything was on fire. And so you had to think about like which fires are burning the brightest right now, and how do you arrange the data so that those most urgent issues come to the forefront. So I can share an example of how we did this in Guatemala, where we had low viral load suppression. So we had gaps, people weren't getting their viral loads collected. And we had 38 facilities across 5 countries in Central America. And our chief of party, went to each facility and tried to get to the bottom of like, what do you need? What can we provide for you? But when we looked at the facilities by their contribution to missed viral loads, so typically your viral load coverage, the denominator is everyone who was on treatment, I think 2 quarters ago. And then the numerator is everyone who's had their viral load collected in that quarter. And instead of looking at percent collected, if we look at the number of missed viral loads, then we're able to see a different picture, that 2 of our facilities are actually driving 80% of our missed viral loads. So how do we rearrange the data? We kind of colloquially call this a missed opportunities analysis. So we can kind of look across the data that we're sending to the donor, use a little bit of algebra to see where our missed opportunities are and which are the biggest drivers of change that, if we address them, would really move the needle. Deep diving into value-based care has been a lot of fun because you've got, the same kind of cadence that we had in HIV. Like you've got your weekly EHR data, and then you've got, 90 days after someone comes to the clinic, their claim gets resolved. And so was the claim paid or not? You won't know that for 90 days, but you still need to like do your weekly workflow. And then, by the end of the year, what you're seeing in your balance sheet is actually the product of processes that were happening 6 to 9 months ago. So you can kind of line that up and see which failure points are, causing the most ruckus in your financing. But you can also look at which ones move quickly, where's the low hanging fruit, which ones are going to take longer to resolve over what time period. And so something I really like about data analytics and thinking about cascades is that you can make it legible. Like you no longer have to panic that everything's on fire because you can quantify that fire. You can have a specialist in each kind of drop off point who is responsible for working on that instead of just like looking at everything and thinking, oh, what am I going to do? Which we
So,
definitely did as well.
but what you've done though is you've started with a clinical challenge, and you have, in a sense, diagnosed it in a systems analysis as a management challenge.
Yeah.
And that's really where you're saying, if I'm catching this correctly, that an organization should view this kind of situation. Does that, I mean, it sounds like then that maybe it's not necessarily the clinician's job to figure out that management issue, but rather someone else who is versed in that and has a way to look at that data and interpret it correctly.
Yeah, someone who understands how systems kind of intersect, understand that complexity, but they're able to wrangle it and make it legible, right? So that you can repair it. So see where those seams are, see how things do change across age and sex. A good example, I think, from HIV is case finding for men and women, right? Like men of a certain age group were not getting tested. And you wouldn't know that, like looking at, testing, 90% of people know their HIV status, right? But when you break that down, men, I think 30 to 35, they don't know their status. And the HIV prevalence in that group is tends to be much higher because of the risky sexual behaviors in that group. And so if you were looking at this and saying like, well, 90%, that's a solid B, right? Instead, you can look at age and sex and kind of get at where those failure points are. I think that's really exciting about thinking of things as cascades.
So it sounds like this perspective is portable in the sense that in
Yeah.
this one place, you found this demographic characteristic, and that you might be able to heighten people's awareness of looking at those kinds of issues elsewhere to be able to uncover similar kinds of challenges or even successes. Is that fair?
Yeah, for sure. I think it's also good to bring in the health workforce as well. So oftentimes I see some of these systems kind of disconnected. So you're looking at within your health facility or within your program, what can you do? But the challenges could be outside of your health system. So in Rwanda, for example, we had a project delivering services at the point of care. Moms delivering babies, and the requirement was like 90% of them should have a uterotonic during the third stage of labor, if I remember correctly. I'm not a clinician. But right, so we broke down the problem, like who's not getting it, and it turns out that the uterotonics are not in the facility, right? And so we're not responsible for the supply chain. So how do we kind of square those two things? How do we figure out who our collaborators are to put pressure on the right places to get the drugs now to our facilities? So it's that whole systems perspective where if you don't think of it in systems, you can't solve the problem in front of you, in my opinion.
So let me look at this or ask a little bit about a temporal approach. I mean, you talk about the challenges with retrospective data reporting, and that it takes a long time in order for those readings, those signals to emerge from the data noise, shall we say. Have
Mhm.
you considered perhaps using predictive analytics to be able to take lessons learned in one place and be able to say, it looks like, given the demography or whatever other kind of factor that you want to put into your approach, might help a system anticipate a challenge that may come up in 6 months or a year or two.
Yeah, one thing that comes to mind is around claims reconciliation at a health system. So part of that is like you submit a claim for a service that your health system provided and that claim got rejected. You can learn from the past on which claims are getting rejected and focus on those, right? Like which are those that are driving the most rejected claims instead of just looking at, the percent that were rejected. And then you can look at, what was submitted and what proportion of those do you think will be rejected. So you're kind of projecting out what you think will happen based on what's happened previously. And we tried to do this in our HIV programs where we looked at, if our achievement against our target was this much, what level of effort would we have to sustain to reach our annual target? So if we were reaching our annual target, are we below the 45-degree line? Are we going to catch up in December? Are we going to catch up in June? How does that kind of shake out in practice? So it really is a lot of bringing in what you can kind of surmise from previous experiences and then giving yourself putting the right assumptions in to kind of predict what's going to happen. So it doesn't have to be super fancy, like, we can predict who's not going to show up to their appointment. Yeah, for sure you can do that, but you can also, use a rule of thumb to understand what your annual revenue is going to be and then walk backwards from that to see where the failure points are.
It sounds like what you're describing is figuring out how to make this data more accessible to the people who are managing these systems. And that, dashboards, of course, are a great help in that kind of thing. But when you were designing dashboards and talking with people, clinicians and others in management of the systems, what did you learn in terms of what they were looking for, or was there something surprising to you as you're thinking about, well, how do we present this information?
Yeah, I think it had a lot of different examples around that. One, I think, is a more cynical example where we were building dashboards of our HIV programs for our home office, right? And the requirement was, we would have these dashboards every month for the program officers. And so our approach was like go to the program officers and try to understand what they want to see in the dashboard. And sometimes they would say, what do you want us to see in the dashboard? Right? And so you do get into some of those situations, but some areas where it works out better is our example from Guatemala, where we had built that data system at the point of care to report to PEPFAR on the number of diagnosed and linked and retained and all of that. But the clinicians were saying, like, we put in this data on these individuals and we know when their next appointment is. Can't we see like who is coming into the clinic that day and which ones have an expired viral load test and which ones need to be tested for opportunistic infections? We're like, yeah, we can do that. We just have to reshape the data you have and to build that dashboard. So there's a lot of reshaping the data, not necessarily putting in the predictive analytics. And the really fun example of that is that we built that in Guatemala and then we took it to Panama and we had the managers in the room and kind of showing them how to use the dashboard. So, they had to go out of their clinic for the day and they couldn't be like monitoring everything. And so they were kind of grumbling, right, about going to a one-day workshop. But we asked them to pull up their data, pull up today's appointments and see who has an expired viral load, and one person gets on their phone and they're like calling the clinic and they're like, these 5 people are coming in today. You have to find them and make sure they get their viral load. So it was so fun to see, like, once you get the right data in the hands of people who can use it, they can act on it. But if we had just shown, like, here's the percent of cases
Mhm.
who are coming in today, they needed to see that line list data in that case.
So really what you're describing is the difference between awareness and actionable information. It's
Yeah, we
good
need
to
to
have
have
awareness, but in order
sure.
to take action, you need a specific kind and form of information. Is that a fair
Mhm.
statement?
Yeah, I think it really, a dashboard is good if it can have that actionable information in it. And, the next phase of that work that we did with the home office is integrating the financial data. So these program officers were more of the budget managers. And so we could look at percent achievement of our HIV testing target and the percent of budget that we had allocated to that. And have we achieved 50% of our target with 50% of our budget or 80% of our budget, right? And so now I have, burned through 80% of my cash. How do I use it effectively? Or maybe I've reached my testing target, and so I don't have to worry about my testing target anymore, and I have budget left over. So can I put that into viral load suppression? And so that was some of the most exciting work that we got to do, was to see that kind of interplay between operations and finance and clinicians, because you don't just say we're going to do it, then you call up the clinician and you're like, we got some leftover money in our viral load budget. What are the most impactful interventions that we can do in the next 6 weeks or however long?
Okay. All right. So let's go back to artificial intelligence, not
Sure.
something where I am by any means expert. Um, but it does sound like with the new agentic AI platforms that can create software and even develop, the kinds of dashboards and things like that you're talking about. Do you see the role that a data scientist plays in this changing to in somewhat similar way that software coders are changing their roles? They're becoming software engineers who are managing an agent that's designing and producing something that other people will use. Do you see data science moving in a similar kind of trajectory?
Yeah, just a second. My
But
dog brought me something he's not supposed to chew
it's okay.
on. Yeah, I mean, it's been wild. One of my favorite tools is a pivot table in Excel, and it's so underutilized. And I spend a lot of time like walking people through pivot tables and helping them see how to use them and writing equations. And now you can just ask ChatGPT, like, help me create a pivot table of this, and it'll walk you through the steps, or it'll say, upload the document, and I'll do it for you. And so I think that that is really going to take off. I think that I've also like looked at a chart and taken a screenshot and gave it to ChatGPT and said, help me analyze this, right? Like, what am I seeing here? And it can kind of walk you through that. So it's really amazing thinking about how it can bring forward those new ideas and new ways of thinking and looking at the same data. Because that's often the barrier that we faced, is that silo data. There's
Mhm.
some of the most interesting questions require more than one database, and there are very few people who can link them together. And so bringing AI in there to augment that approach, I think is so cool, and hopefully will lead to more data analytics and good stuff. I'll have
So one of the things that I sort of also took from your comments today is you did a great deal of work in multidisciplinary settings. I mean, and I'm sitting here in a classroom with health informatics students, and so I'm thinking their future is going to be quite different than certainly my past. And so how do you see data scientists fitting into teams where you've got managers and clinicians as well as other people in very technical roles? Um, how did you find you could communicate across these disciplinary barriers, so to speak?
Yeah. Um, I think a lot of patience is probably the answer to that. But one of my reflections on AI taking our jobs comes from a recent podcast I think I was listening to. I don't remember the name, but they were talking about how taxi drivers used to have really valuable knowledge in their head, right? Like that's why you take a taxi because they know where all the streets are and they know the fastest way to get somewhere. And when Google Maps came along, we didn't need taxi drivers anymore because Google Maps and our phone could tell us where to go. And so that was an instance of technology, like solving for the hardest part of a job, and that put people out of work, right? The other example was you could think of, and I don't think this is the example she gave, but if you think of clinical documentation, right? You've got a doctor writing their notes at the end of the day, or a nurse doing documentation after her shift in pajama time, right? That is maybe not the best use of her training and skills. So if AI can scribe and write those notes and free up time for the clinician to do more of that work that they're really have a comparative advantage in, I think that's where AI can enhance your job and not displace you from your job. So I think for data science, like AI can write pretty good code. It's not writing code anymore that is the barrier to entry. And I haven't tried it, but it can probably, take the your software back end and rewrite it to
Mhm.
be fire compliant, right? I'm sure it can. Um, and so that's not the big driver anymore. It's that thinking piece and the communicating the results. And I think about my PhD training often, like our training was reading articles in the best journals and critiquing them. you know?
Mhm.
And
Mhm.
so when I look at what AI gives me back, when I ask it something, I'm reading it and critiquing it and pushing it forward and not just taking it at its word. So I think that's where AI can augment you instead of replace you.
So it sounds like then we should approach this change with some, I guess, caution,
Yeah.
uh, that it does hallucinate, not as much as it used to.
Hmm.
And the hallucinations are in some ways more subtle than they once were.
Yeah.
But this is perhaps, and I'll just make the statement, you may react to it as you see fit. This is a set of tools that we really should become conversant in using and embrace this change because it's looking like it's inevitable.
Yeah, the genie's out of the bottle, right? Like it's never going away. And I think about like, don't take it away from me because I really want it. And like it helps me do my coding faster. It gives me an opportunity to get that data table that has been, I could have spent hours like reshaping it and making it the way I wanted, and it can write the code in seconds and implement it even faster. And then I get to spend my time analyzing and thinking through what the next step is and all of that stuff. That's more fun that it can do some of it, but it can only do what you ask. It doesn't know what's in your head and your ideas and how to implement that. So
So it sounds like um, there was a movie, I don't even remember what it was anymore, where this guy was noteworthy for how he ordered lunch at a very
okay.
fancy restaurant. And he would not only say, I want to have this particular thing, but I want it prepared in this way, with not with this stuff, but with this
Yeah.
other stuff. And it was like he was the chef. and he was
Mhm.
telling the chef how he needed to prepare this man's lunch. So
Mhm.
it sounds to some way, what you're saying is we need to be careful with AI in what we tell it. Otherwise, we'll get results that won't be very satisfying.
Yeah, I mean, we all have our preferences, right? Maybe I was fine with what that chef prepared. I don't know as much about it.
But
Um,
but
I
part of
think
it is also your knowledge that you bring. You mentioned earlier pivot tables.
mhm.
And having seen your work with pivot tables, you are quite expert at it. But even though an AI may be able to do this, you understood a lot of what you wanted and how things needed to look like at the end. And you had an
Yeah.
appreciation for what was involved in actually constructing it. And it sounds like that, in a sense, was a great benefit to you, that you had this fund of technical expertise um, when you're directing this AI to do something for you.
Yeah. Yeah, I mean, I'll share an example of when I was using it to code something recently. I explained what I wanted and, gave it the names of the variables and it wrote the code and then I inspected it, right? Like I was like, no, that's not working out because it shouldn't be like this. So I gave it that feedback. I was like, oh, okay, I fixed it. And then I looked at it again. I'm like, no, this isn't quite right. This isn't what I wanted. And then I tried it again, and then eventually it was what I needed. And so it even said to me like, "Good job sticking with it." Like, okay.
So maybe the takeaway lesson there is essentially this is a tool that doesn't necessarily get irritated at you.
Yeah.
Yeah, it will take an infinite amount of input,
For now,
but you
yeah.
just have to have the determination for it to get to where you want it to be.
Yeah, I think that's part of it. You have to have that vision of what you want it to look like and um, put your own spin on it or flair on it. You can't just take the output and use it.
But it also sounds like that vision on your part is something that you have not just it's not just a technical capability on your part, but you have an idea of what is that manager going to want to look for? What does that clinician need? So there's a great deal of what you have learned from these other people and other disciplines that you can pour into the solution to the
Yeah.
challenge that they have.
Hmm. Yeah, that kind of knowledge work is, I think, still going to be valuable.
Okay. I think we'll leave it there.
Okay,
Thank you very much. This has been a very interesting conversation.
good. I'm glad.
All right. And we will see everybody next week. Amy, you're invited.
Okay.
All right. Thank you.
Bye, everyone.